process. So this is a very typical patient with critical limb-threatening ischemia, 86-year-old. She came into the hospital with debilitating rest pain and then got transferred to my hospital when she was found to need heart surgery. She wasn't too interested in her heart surgery. All she cared about was her legs, wanted to get back to dancing. She had very reduced ankle brachial indices, 0.31 on the right, 0.35 on the left. And when someone checked toe pressure, she essentially had no flow at the toe level. Over the course of me meeting her over the week or so after her heart surgery, she developed bilateral heel ulcers. This was actually the better of the two limbs. This is the angiogram, and you can see pretty well preserved aortic inflow and iliac arteries, although she does have some disease of her proximal left iliac. If you then kind of follow it down into the thigh, you can see a pretty severely diseased superficial femoral artery and popliteal artery, and then you can see the runoff is not perfect, but she's got one pretty good runoff vessel. So, what are you thinking when you see this kind of an angiogram and this kind of a patient?
Yeah, so there's a few things going through my mind. She's here with rest pain, which of course is very, ischemic rest pain is very painful. It's hard to really enjoy anything in your life with that. But she also has these wounds on her heels, and heel wounds are particularly dangerous, particularly risky for limb loss, because if that sort of gets deeper and gets to the bone, there's not a lot of surgical resections you can do that really maintain a lot of function or ability to walk. So they're particularly high risk, wounds when in my mind. And then thinking about sort of the patient herself, she's fresh out of cardiac surgery. So there's certainly, significant concern for performing operations in this person. She's newly revascularized, which is great, but she's also still in a window where she can have a lot of complications post-surgery. So kind of balancing the need for limb loss with her general risk of surgery is certainly of concern. And then sort of lastly, looking at this anatomy that these angiograms are demonstrating, she, as might be expected from someone who has, the most severe form of peripheral artery disease, she has multi-level disease. So there's some in the iliacs, there's some in the SFA popliteal lesion, and then certainly some in the tibial segment as well. So she represents a pretty complex anatomic picture. In an ideal world, someone fresh from heart surgery, you'd want to do sort of a minimally invasive approach. But on the other hand, with disease this complex as far as her anatomy goes, I'd be pretty suspicious of how durable your revascularization would be if you address this from an endovascular standpoint, especially that popliteal segment with those very sort of chunky looking calcific plaques. I'd be pretty worried. May not respond well to endovascular approaches. So, certainly this is a complex patient, but I would need to have some multidisciplinary discussions with her cardiologist and such, because I think that ultimately the leg might be better served with a bypass if we think that she could tolerate it from an overall clinical standpoint.
Yeah, that's a great answer. I think it's a good case because it just highlights the complexity of the decision tree and the algorithm. And historically, we haven't had a lot of good data to support this. We did recently publish the results of the BEST trial that was focused on this very question. The BEST CLI trial, recently published in the New England Journal, looks at patients just like this that are considered candidates for both kind of the more invasive surgical bypass option and the less invasive endovascular option, and actually found that surgery did a little bit better. But your kind of thought process highlights the many different variables we have to think about as we're trying to make that tough decision. And to your earlier points, we absolutely want to bring in the the kind of thoughts and desires of the family and the patient. And as I kind of alluded to, she's a bit of a spitfire, and all she cared about was getting back on the dance floor. And I was concerned about the same things, really giving her a durable result. So let me push you a little bit. What do you think you would kind of, if she pushed you and said, gee, what do you think is the best thing for me? What do you think you would recommend?
With the knowledge that I would need to know a little bit more about her current cardiac status after surgery, I would say if I did a brief attempt at an endovascular, crossing of these lesions near the popliteal on this initial angiogram, you might consider trying an endovascular approach, but I would really lean more towards a bypass for this patient. I think that for somebody who's coming off the dance floor, who is very functional at baseline and who wants to get back to that, I think that that's her best bet. And I think a lot of times the first thing you do to a patient probably has the best chance of really solving their problem. I prefer not to have a situation where I'm trying one thing and then trying another and trying another, because every time you wait and see if that worked, I think you run the risk of losing more tissue. So with the assumption that, her cardiac status is good enough to handle general anesthesia, I'd probably urge her towards a bypass at this point.
Yeah, I think a lot of people would probably attempt an endovascular revascularization in this setting, but I kind of had the same conclusion that you did. It highlights the point that there are times when we just accept even a little bit of tissue loss. If someone has a little bit of dry gangrene of their toe or an ulcer that doesn't seem to want to heal, but it's not really bothering them, certainly appropriate to just kind of tolerate that and treat them conservatively with kind of close management and close follow-up. There are other times when really the right answer is to proceed with an amputation, a primary above or below knee amputation, depending on their ambulatory status. But if one were to move to revascularization, this highlights that often we do have a choice. I wanted to give her a real durable result, and so I did undertake a bypass. She did absolutely great. I did the other side a couple of weeks later, and about 3 months later, she had healed everything up and was doing great, and really pleased with the result.